Hi, Zach. It's Dr. Kemmery. So I'm going to go over your mind map really quickly. Self-injection for diabetic patients at home is a skill that you could be teaching, right? And that's appropriate for the mind map. So what I'm going to do is I'm going to go through your theories first, and then I'll break each theory down. So let's start at the top. So you have here humanistic theory. Remember, humanistic theories are student-driven, right? And it's at their own time or their own pace, really, or it's part of some of the theories. Now, you have listed here as the theorist for Rogers. Rogers' theory is experiential learning, right? So that would be your theory that would go here. Humanistic theory would be broader, right? That's a broader theory category because Maslow and Bugental are other theorists under the humanistic broader category of theories, right? So this theory, experiential learning, should have been here and then listed as Carl Rogers because I'm assuming that you want to be specific to that theory and that theorist, right? So remember, all humanistic theories, again, are student-driven, right? And that needs to be the focus or the center of that theory, right? So the view of knowledge is that new knowledge builds on new skills, right? So they want to learn, right? It's that self-actualization piece that Maslow talks about when we talk about knowledge. The view of learning is that these learners will evaluate themselves and succeed and pace themselves because they want to self-actualize or they want to achieve, right? The view of learning. So the student has autonomy, you are right, and control, right, over that particular thing that they're trying to learn. And as the educator, we are facilitators, right? We facilitate that growth by constructing educational environments that encourage learning, that encourage that self-discovery, right? By providing formative feedback first and then summative feedback, right? And then how would you apply it to this particular case, the self-injection, right? Supporting their healthcare team and their loved ones to understand how to manage their care and evaluating that process, right? And then giving them feedback, right, during that formative stages, right, that formative stage, and then again at the summative stage, when they have actually achieved self-injection, right? Social learning theory is the theory of Bandura. Bandura I'm very, very well versed in. So Bandura actually talks about self-efficacy, right? That is the cornerstone, if you will, of social learning theory. Without self-efficacy, Bandura couldn't have constructed the social learning theory. So when you think about social learning theory, it's actually a bridge between behavioralism and cognitivism, right? So behavioralism, where people will learn in increments based on that response to positive stimuli in the environment, right? And cognitivism is the processing of knowledge, right? But it's all hinged on self-efficacy. So when you look at this view of knowledge here, what you've given us, you're saying that knowledge is attained from learning from those around one another through modeling behaviors, reactions, and attitudes. That sounds more like, when you think about it, that sounds more akin to transformational experiential learning, right? So social learning theory, part of it, yes, is that social group, but it's also the context, right? So you need to just be careful that it's all about how one feels in that learning situation. So if I believe that this is my peer group and I believe that I can achieve like the others, then I'm okay. But if I'm in what we consider their peer group, other patients with diabetics or other patients with diabetes, or in the support group or whatever, or giving them examples or exemplars of other patients with diabetes if you're in the home, they may not see themselves as part of that peer group, right? So then social learning theory wouldn't necessarily work as well. So you just have to be careful about that. The role of the learner, right? The role of the learner, attention, motivation, motor reproduction, motivation are the 4 components to observational learning. I think that is supposed to be here with the view of the learner, right? And the behavior is learned through observation. It is through observation, but it also is, again, through modeling, right? I'm not sure with a holistic approach by incorporating intellectual and emotional teaching goes into the view of the learner, though. So I'm not really sure where you wanted to put that. Role of the student and the role of the educator. I think maybe this is supposed to be down here with the role of the educator, right? And the learner doesn't, or the student just doesn't observe, right? The student has to interact. The student has to realize that they can do this particular thing, right? And have that self-belief, right? That self-efficacy. So I think these maybe got a little confused, and I think your role as a student is not as clear for this theory. How this theory would be applied for self-injection, obviously the self-motivation, right? That self-efficacy, can they do it? You know, not just do they think they can, right? If I think I can, I probably can. And if I think I can't, I'm definitely right? So one of thinking like that, right? And the learner demonstrates the injection for the educator, right? But how the learner can also practice on an object, right? To move on to self-injection when more comfortable. That would be not more comfortable, but when their self-efficacy increases, right? So giving them a lower stakes injection tool, like, simulated skin, simulated subcutaneous tissue, or the orange, right? To inject into, and then their self-efficacy builds with their skill set of injection, and then moving on to themselves. So if you're going to use social learning theory, think that out a little bit. Information processing theory. Actually, information processing theory, although begun by Miller, right, has been pulled out and is actually, there are many, many theorists who can be found under that umbrella of information processing theory. So I'm thinking about Atkinson and Sharifin in 1968, right? They actually talked about information processing, so bringing that further into the future. And then Bransford in 1972, and then Rumelhart, and most recently Rumelhart and McClelland in 1986. So taking Miller's early theory, and actually bringing that forward, right? Because information processing has changed, right? And has been affected by the changes in educational environments and in technology and the use of technology. So you want to be sure that when you're talking about a theorist, you're actually talking about a theory that is current, evolving, and changing, right? So in knowing that, you would need to, if you're going to talk about information processing theory, not just talk about Miller, but to add in the rest of the theorists for this particular theory, because they're all working within that wheelhouse of information processing, right? So the view of knowledge is memory of information or action is tested and repeated. So that is correct. So it's more or less, because this is a cognitivist theory, which I call the computer theories, and they're very focused on processing of knowledge and acquisition of knowledge through process, right? That's going to be a hallmark of any of the theories that are the subcategory theories for the cognitivism theories, right? So you want to make sure that that you make that clear if that's going to be the theory that you use. Cognitive dissonance theories by Festinger. Cognitive dissonance is where you have a change in perspective, right? In perception, right? In your paradigm, the way you think, right? And then push that from what you were before into something new and different, right? You can never go back to where you were before. So even if you don't change significantly or change the way you think significantly, there's going to be like a catch, if I call it, or like a pebble in your shoe, right? or there's something that's kind of eating away at you that wasn't there before, because you have this broader base of information, right, or different knowledge that you need to acquire, right? It's not that they search for consistency. They search for balance, right? So they're looking for balance. That's the theory. That anything that is unbalanced in a system, right? If you look at it, a holistic approach to humans, right? To all human life or all life, we're all in a battle for homeostasis, right? We want to be balanced. We want to be even, right? No big waves, no rocking the boat. Well, that's what cognitive dissonance theory talks about. It's not necessarily inconsistency. It's imbalance, right? It's imbalance would be the word that I think would be better than not consistent. And the view of learning is that attitudes and behaviors are modified to limit or minimize that disconnect, that dissonance that people experience, right? So that's good. And learners, the role of the student, is to reduce that, is exactly to eliminate or limit that disconnect, that dissonance, right? To find that balance again in their mind, right? Of what they know, or in some cases who they are, right? So in what they believe is true, right? The educator needs to support students during that disconnect or that dissonance, and providing factual information is often a good way to do that, or challenging students who have a particular mindset and creating that dissonance, right, in the classroom to kind of push the learners forward, right, to push them forward into something that they may not already realize, right? So helping the learners overcome their fear of needles, right? Fear isn't necessarily dissonance. It would be the disconnect or the dissonance between not being able to self-inject and having to self-inject. So that's where your dissonance lies, right? The mechanism and all of that. Because if I really believe, right, that now my diabetes is progressed to the point where I need to self-inject, then that's not going to be a disconnect with what I learn and what I do, right? So fear is one thing, but it'll be easier for me to overcome that fear, that emotion, if I truly have learned and believe that I need this insulin, right? I need to walk 10,000 steps a day, or my blood pressure will go up. I need to eat healthy, or I'm going to get diabetes, right? So people learn things, and their behaviors are couched by those changes, by that cognitive change, right, in that person. And I think that's it. I think we're good. So if you have any questions about any of my feedback, please feel free to email me.